Welcome to our video on miscellaneous connective tissue disorders. Let's begin. Here's a list of topics we're going to discuss in this lecture. Let's start with Sjogren's syndrome. We'll discuss definition, risk factors, clinical features, diagnosis, and management of Sjogren's syndrome. Sjogren's syndrome is a chronic inflammatory autoimmune disease characterized by lymphocytic infiltration and destruction of the lacrimal and salivary glands. It is most commonly seen in women. There is primary and secondary Sjogren's syndrome. Secondary Sjogren's syndrome is associated with a connective tissue disease like rheumatoid arthritis, systemic sclerosis, lupus, or polymyositis. Patients with Sjogren's syndrome have increased risk of non-Hodgkin lymphoma. Patients with Sjogren's syndrome present with xerophthalmia, or dry eyes, and xerostomia, or dry mouth. A combination of these two is called Sicca syndrome. Dry eyes are usually described by the patient as a feeling of having sand in the eyes. Dry mouth causes tooth decay due to the reduced antibacterial function of the saliva, which also leads to halitosis. Patients also present with extraglandular manifestations such as arthalgias, fatigue, and Raynaud's phenomenon. Let's discuss diagnosis. In laboratory testing, complete blood count, erythrocyte sedimentation rate, and C-reactive protein are typically ordered. Anti-SSA antibodies, also known as anti-Rho and anti-SSB antibodies, or anti-LA, are the hallmark in primary Sjogren's syndrome. Anti-nuclear antibodies and rheumatoid factor can be positive as well. Schirmer's test can be performed. A biopsy is the most accurate way to diagnose this condition and reveals the presence of lymphoid infiltrates in the minor salivary glands. This is how a Schirmer's test is done. A strip of filtered paper is kept at the margin of the lower eyelid, and the patient is asked to keep his eyes closed for 5 minutes. Then the strip is removed and the length of the wet strip is measured. If the length of wet strip is more than 10 millimeters, it suggests normal tear production. But if it is less than 5 millimeters, it means that there's inadequate tear production. Let's take a look at this biopsy of a salivary gland. There is focal lymphoplasmacytic infiltration associated with Sjogren's syndrome. Coming to management, for dry mouth, we recommend maintaining good oral hygiene and use of artificial saliva. If symptoms are more severe, we consider the use of muscarinic agonists like pilocarpine or cevimeline. As for dry eyes, we initiate the management by administering artificial tears and lubricants. However, if these fail, we consider the use of topical cyclosporine or lifitegrast. If the patient has extraglandular manifestations, pharmacologic therapy is indicated and includes glucocorticoids, hydroxychloroquine, and disease-modifying anti-rheumatic drugs like methotrexate. Lastly, in states of secondary Sjogren's syndrome, we should also treat the underlying connective tissue disease. Now let's do a flash quiz. A 45-year-old woman comes to the physician due to enlarged left cheek. The swelling started 3 weeks ago and it has enlarged rapidly. She has a long history of difficulty eating salty foods due to dry mouth, and she constantly feels like there is a foreign body in her eyes. She also complains of diffuse joint pain. The physical exam reveals unilateral firm mass. What is the best next step in the management of this patient? This woman reports rapidly enlarging swelling on her left cheek. The physical exam reveals unilateral firm mass. She has a long history of difficulty eating salty foods due to dry mouth, and she constantly feels like there is a foreign body in her eyes. She also complains of diffuse joint pain. Dry mouth, dry eyes, and diffuse arthalgia point toward the diagnosis of Sjogren's syndrome. Rapidly enlarging facial mass in the context of Sjogren's syndrome raises suspicion for secondary marginal zone lymphoma in the parotid gland, which is a type of non-Hodgkin lymphoma. Therefore, the best next step in management of this patient is to obtain a biopsy of the mass to rule out lymphoma. Let's discuss mixed connective tissue disease next. We will discuss definition, clinical features, diagnosis, and management of mixed connective tissue disease. Mixed connective tissue disease is a generalized connective tissue disorder with overlapping features of SLE, systemic sclerosis, and polymyositis. It's a female-dominant disease, typically in the second or third life decade. The clinical features of our condition include nonspecific symptoms like low-grade fever, arthalgias, and fatigue. Raynaud phenomenon with swollen hands and fingers may be present as well. There is severe arthritis, more severe than the arthritis associated with SLE. Pulmonary hypertension may be found, and it is the major cause of death. In mixed connective tissue disease, the severe renal or CNS involvement is absent. However, trigeminal neuropathy may be found as initial manifestation in some patients. As for the laboratory findings, anti-ribonucleoprotein antibodies, UNRNP, is found in almost 100% of cases. Positive serum ANA is found in the great majority of cases. Other antibodies frequently found include anti-phospholipid antibodies, rheumatoid factor, and anti-double-stranded DNA. Coming to management, the treatment for this disease will vary depending on what specific disease predominates. Glucocorticoids can be used. When there is pulmonary hypertension, choices of therapy include prostacyclin analogs like epoprostenol and endothelin antagonists, such as bosentan. All right, time for another flash quiz. A 41-year-old woman comes to the physician due to pain in her shoulders and thighs for the past 6 months. She has difficulty combing her hair and climbing on the stairs. Physical exam reveals malar rash on the face as well as curved and stiff fingers. Which antibody is specific for this patient's condition? This woman presents with pain in her shoulders and thighs for 6 months. She has difficulty combing her hair and climbing on the stairs. Proximal muscle pain and weakness raises suspicion for polymyositis. Physical exam reveals malar rash on the face as well as curved and stiff fingers. Malar rash is characteristic of SLE, while curved and stiff fingers, also known as sclerodactyly, is characteristic of scleroderma. Since this patient has features of multiple autoimmune disorders, the most likely diagnosis is a mixed connective tissue disease. The most specific antibody for mixed connective tissue disease is anti-UNRNP antibody. Let's lastly discuss Morton neuroma. We will cover general characteristics, diagnosis, and management. Morton neuroma is an interdigital neuroma of the foot that typically affects the third interdigital space. It may be caused by repetitive foot overload, for example, overpronation and use of tight shoes. Patients usually describe the discomfort as standing on a pebble. Also, there is a burning pain sensation between the third and fourth toes, accompanied by tingling and numbness. To diagnose Morton neuroma, the physician will perform a physical examination and will detect a clicking sensation when palpating the space between the third and fourth toes with squeezing of the metatarsal joints. An ultrasound can be ordered to visualize soft tissue structures like a neuroma in this case. Here's an image of Morton neuroma. As we mentioned earlier, it is commonly found between the third and fourth metatarsals. As for treatment, a conservative approach is preferred first, such as arch and metatarsal support, foot pads, and strength exercises of intrinsic foot muscles. If these measures do not relieve the patient's symptoms, then steroid injections are considered. In some cases, the pressure on the nerve can be relieved by cutting nearby structures such as the intermetatarsal ligament. If other treatments don't ameliorate the condition, a removal of the nerve can be successful, but it can cause permanent numbness in the affected toes. All right, let's do another flash quiz. A 35-year-old woman comes to the physician complaining of pain in her left foot. She feels like she constantly stands on a pebble. Physical exam reveals pain and clicking sensation when palpating between left, third, and fourth metatarsal heads while squeezing the metatarsal joints. What is the best next step in managing this patient? This is a woman complaining of pain in her left foot. Sensation of standing on a pebble and clicking sensation when palpating between third and fourth metatarsal heads while squeezing the metatarsal joints are consistent with Morton's neuroma. The best next step in management of Morton's neuroma is conservative measures such as arch support and using foot pads. Let's end our lecture with a board-style question. A 32-year-old female comes to the physician due to pain and stiffness in her multiple joints for the last 4 months. Symptoms are more severe in the morning and improve during the day. She also feels pain in her muscles, especially when she wants to stand from a chair or climb the stairs. The patient has noticed that she sunburns very easily, and she complains of chronic heartburn for which she takes pantoprazole. Physical exam reveals weakness and tenderness in deltoid and quadriceps muscles, malar rash sparing the nasolabial folds, and tense skin over the fingers. Laboratory tests are pending. Which of the following is the most likely diagnosis? A. Mixed connective tissue disease. B. SLE. C. Rheumatoid arthritis. D. Systemic sclerosis. Or E. Polymyositis. This patient has pain and stiffness in multiple joints. These symptoms are more severe in the morning and improve during the day. This is classic description of inflammatory joint pain, and it fits the description of either rheumatoid arthritis or SLE. This patient has proximal muscle pain, which points toward polymyositis. Chronic heartburn suggests a GI manifestation of systemic sclerosis, while sunburn and the malar rash sparing the nasolabial folds are consistent with SLE. As we can see, this patient exhibits the symptoms of multiple different connective tissue disease. Therefore, the most likely diagnosis is mixed connective tissue disease. Here's a slide reminding us of mixed connective tissue disease. Let's discuss other answer choices. Option B, that is SLE, is incorrect because it would not explain heartburn, muscle weakness, and tense skin. Option C is incorrect because rheumatoid arthritis would not explain sunburns, malar rash, heartburn, and tense skin. Option D is incorrect because systemic sclerosis is not characterized with malar rash or muscle pain. Finally, option E is incorrect because the patients with polymyositis do not have arthritis, sunburns, heartburn, or malar rash. And that concludes our lecture on connective tissue disease.